Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back Richard Lawhern. He's a patient advocate. His KevinMD article is titled, "Everything the Government Thinks It Knows About the Opioid Crisis is Wrong." Richard, welcome back to the show.
Thank you very much, Dr. Foe. I appreciate the invitation.
We'll get into your article in a little bit, but for those who didn't listen to our first episode together, just briefly share your story and journey.
Well, I am a patient advocate. I'm not a clinician. However, my training is in technical analysis of data and research protocols. I got into patient advocacy about 26 years ago when my wife came down with what seemed at first to be some form of dental pain. It took us a year and 6 physicians to find out what was really going on, which was a rare form of facial neuropathic pain called trigeminal neuralgia. I got active with the U.S. Trigeminal Neuralgia Association, which has since been rebranded as the U.S. Face Pain Association, as basically a research analyst and writer for the material they wanted to present on the web, and generally got involved rather deeply in social media as a moderator for peer-to-peer support groups, patient support groups, and as a writer in the field of neuropathic pain. About 12, 15 years ago, I started hearing from patients who were having an increasingly hard time getting treatment with opioids for various forms of neurologically based pain, because not everybody responds to medications in quite the same way. And I was gradually drawn into roles that involved understanding the medical literature and helping patients to find authoritative information on a fairly wide range of medical disorders, and authoritative information that we could really trace to sources that were credible.
Let's talk about the KevinMD article that you chose today. Everything the government thinks it knows about the opioid crisis is wrong. So, provocative title. Tell us, how did your article come together?
Right, fine. And let me kind of start with a story that I sometimes tell. Last year, July, I was invited down to Florida to address a meeting of the Florida Society for Interventional Pain Physicians as a patient advocate. And as part of a 1-hour discussion with a little over 100 people, I asked a series of questions to kind of help the audience get comfortable with itself and comfortable with me. Primarily because I was focusing at that time on the circulating draft of the CDC opioid guidelines that was still in draft in July of last year and was going to be published in October. I wanted to be sure the audience had some exposure to it. But I asked questions about where people were coming from. And as the questions became a little more specific, the number of hands that went up in the audience started dropping. And the last question that I asked was very germane, and it's very germane to the venue that you operate as a podcast operator. I said, how many of those in this room are board certified in both addiction medicine and pain medicine? And out of an audience of 100 plus, maybe 4 hands came up. But the final question was, how many of you are also technically trained in the evaluation of trials protocols? And only 1 hand went up. And I observed to the audience, you realize, of course, that as clinicians, you are dependent on the goodwill and sense of proportions of writers whose abstracts you're reading, but whose substantive methods you don't understand. And there is substantial concern in medical communities these days that the peer review process isn't helping you, because too much is being published that just doesn't hold up under close examination. And I was there to talk with them about that, which is what led me in part to the article we're talking about today. When I say that the US government doesn't understand most of what it thinks it knows about opioid addiction and about medical opioids is wrong, I start from a theme that was probably first voiced by a journalist by the name of Johann Hari. He gave a TED talk some years ago that has since been seen by about 20 million people. And his theme was indeed that everything you think you know about, and this was in general terms, everything you think you know about opioids is wrong. There is another much more grounded and much more scientifically surrounded narrative here by economist Ann Case and Nobel Prize winner Angus Deaton in their book, Death of Despair and the Future of Capitalism. These are very credible sources, and what they have to say is basically that the nature of our opioid epidemic has been fundamentally misdefined.
Okay.
Because it is not caused by exposure to medical opioids or indeed by any supply-based parameter. It is caused by the social determinants of health that have resulted in increasing desperation among large bodies of people who are basically facing 50 years of wage stagnation, the hollowing out of both rural and inner city communities, the destruction of families, the increasing wealth inequality in the US. These are all very large picture issues. But what they had to say basically is people get to be vulnerable to the appeal of distractions like opioids, street opioids specifically, not medically prescribed, because they're desperate, because they've run out of options. They're basically, it's a crisis in hopelessness, not in opioids. It's been misdefined fundamentally. Now, with that in mind, I started digging, and I have been digging now for much of the last 10 years, on research around the whole idea of what really is involved in causing our opioid epidemic. And what I come up with is very much grounded in data that is published by the US CDC and SAMHSA and the National Institutes of Health and a number of other places. And what that data tells us is that for at least the last 13 years, there has been no substantive relationship between rates of opioid prescribing versus rates of either hospitalizations or opioid-involved overdose death. There is no statistically interesting relationship. In fact, the correlations are exactly in the opposite direction. Now, that, of course, we remember the old remark that correlation is not cause, but a lot of people who are writing in this field these days forget that. Bottom line here is when you do state by state, simple linear regression for the last roughly 15 years between rates of prescribing or any analog for them, notably the volume of sales, in opioids sales, and rates of either hospitalizations or opioid-involved overdose type deaths, and that means an opioid of some kind will be involved, not always a medical opioid, and not always as the primary cause. If you look at that connection, what you find out is that the correlation is inverse since 2012. Opioid-related deaths have tripled in the same period. You can't get that result in the statistics for any medical model that proposes opioid prescribing as even a significant cause of hospitalizations or death. It can't happen. And yet the entire policy discussion is ignoring that.
Why do you think that point has been ignored by the public health authorities?
Well, now that's going to get us into an area where I got to point some hard fingers. The point's being ignored because it basically reveals that the US CDC developed its guidelines around a political agenda. And, it's like, damn the torpedoes, full speed ahead. We're not going to accept any other answer. I would say, and I realize I'm being something of red with his little remaining hair on fire when I do say this, the US CDC knew there was no correlation, ignored it, and deliberately attempted to sidestep it, because in order to acknowledge it, they would have to acknowledge publicly that what they had produced was fraudulent. And by that, I realize there's an accusation here, and I'm not making it casually. US CDC knew perfectly well that the statistics didn't support them, and they ignored the statistics. That we can prove. And in that regard, the writing of Dr. Chad Collis is very important, and he has some stuff that's fairly recently out, again during the same cycle of commentary to the updated CDC guidelines. What's basically happening here is that there's a lot of money involved in chasing the idea that the big pharma companies did it to us by overprescribing and by encouraging overprescribing. But overprescribing didn't produce this crisis. So realizing that this again is is evidence-based, but it's a position that many people, even in medicine, are having a really hard time with. Because what it means is we've not only done it wrong, we've destroyed tens of thousands of lives and imprisoned physicians because it's wrong.
Tell us some of the ramifications of the misinterpretations of this data.
Sure, let's do that. Let's take an example out of 2016. Basically, what the CDC claimed was that there is reason not to prescribe opioids over 90 morphine milligram equivalents per day. And that term is used very widely in CDC 2016. It's also used multiple times in CDC 2022. However, there is no consensus on on how you measure or model MMED, and large numbers of clinicians, including the leadership of the American Medical Society, have explicitly labeled MMED as junk science, but it occurs throughout the CDC guidelines. Another example in the guidelines is both versions of the guidelines proclaim loudly that non-opioid and indeed non-pharmacological pain treatment is preferable, quote, quote, to opioids in common practice, both for general practitioners and for specialists. But when you get into the references that supposedly justify that position and you look for the details, which is what I did with help from a couple of clinicians, what you discover is that all of this relies on reports published by the Agency for Healthcare Research and Quality, AHRQ, and particularly by or involving one author. His name is Dr. Roger Chow, or at least the outcomes review discovered was that out of about 5,000 trials of non-opioid, non-pharmacological therapies of various types, just over 200 of them managed to pass rigorous quality criteria. In other words, they were sufficiently well-grounded that they could be regarded as pretty serious research in the field. When you look at those at 200 plus, I think it's 218 trials, over 150 of them list the medical literature that supports them or the medical trials data that supports them as weak, evidence weak. They also show you that the improvement level in pain levels is generally not more than 2 levels on a scale of 10. They do not ever, in any of that literature, do a direct comparison between opioid pain relief versus non-opioid pain relief. It isn't there. It's not in any of those trials. And yet CDC claims that the use of non-pharmacological techniques is preferable, quote, quote. By no stretch of a livid imagination can that assertion be held as truth. It's not. It's an outright misrepresentation of what the literature actually establishes. That's only one of several examples. Here's another one that's much, much bigger. We've known for 20 years that individual patients respond differently to medications because of their genetics. There's a whole process of breakdown for primary opioids and other medications in the liver. And it turns out that there's a series of 6 enzymes that the liver uses in accomplishing the metabolic breakdown of opioids and many other meds. However, we know that there are at least 2 different modes of response that don't fit the typical. One is people who are very resistant to opioids, who have a very poor metabolism for them, and others, and this is recognized in FDA publications, others are hypermetabolizers. We have people running around in large numbers, like in the term in millions, who literally can take enough opioids to knock over a horse and look at you and hold a cogent conversation and basically not even notice. But none of the trials literature on pain reflects that kind of comparison. And yet what we get is an assertion by CDC that, oh gosh, oh gee, there are so few long-term trials that we really can't consider that opioids have proven their effectiveness. That's disingenuous. It's fundamentally disingenuous, because what we've got is long-term trials that run into the fact that large parts of the trial population may either be over responders or under responders that are not accounted for, and the protocols are not designed to address them. So what we have is a misattribution of ineffectiveness, very clearly so in 2016 and to some degree in 2022, where the CDC writers basically tried to make a politically determined case. And they ignored the fact that the literature they were examining doesn't in any way address the genetic effects of pain metabolism. In fact, when you go and you read through the full document issued as an updated document, the term genetics occurs once in 2022, just once, and it's peripheral. And yet what we've got is a trials literature that doesn't account for the fact that large numbers of the population don't respond as it is assumed that they should respond by the writers of that document.
We're talking to Richard Lawhern. He's a patient advocate. His KevinMD article is titled, "Everything the Government Thinks It Knows About the Opioid Crisis is Wrong." Richard, tell us about the path forward. What do you think should happen next? And maybe you could wrap up with some take-home messages.
Sure. What I think should happen next is that the U.S. Congress should introduce hearings and then legislation to remove the U.S. CDC from all policymaking roles with regard to the practice of pain management. That is not a trivial ask, I realize that. But the bottom line is that they've had two chances at that, and they messed it up royally both times. And potentially, they messed it up as a consequence of a political agenda that does not reflect the science of treatment for pain management, and should not affect regulation, but is indeed very negatively affecting regulation. That would be my sum up on the article. And I think the article is also worth a good read because it's deeply referenced, and I certainly want to promote that outcome.
Richard, thank you so much for sharing your time and insight. Thanks again for coming back on the show.